Then I'll have links to our website, and then our YouTube page, which we will eventually upload this recording onto, and you can access it at a later date once we get that done. And then we'll also send the handouts for today as well in that follow-up email. And since you registered, you don't have to send anything in to receive this because we have your email on file. We want to take time to acknowledge the land. And so I'd like to read this land acknowledgement to you if you bear with me for a minute. We want to take the time to acknowledge the land and pay respect to the indigenous nations whose homelands were forcibly taken over and inhabited. Past and present, we want to honor the land itself and the people who have stewarded it throughout the generations. This calls us to commit to forever learn how to be better stewards of these lands through action, advocacy, support, and education. We acknowledge the painful history of genocide and forced occupation of Native American territories, and we respect the many diverse indigenous peoples connected to this land on which we gather in time from immemorial. While injustices are still being committed against indigenous people on Turtle Island, today we say thank you to those that stand with indigenous peoples and acknowledge that land reparations must be made to allow healing for our indigenous peoples and to Mother Earth herself. So this acknowledgement came from three of our former members of the Meskwaki Nation, Ella and Keely Driscoll and Sean A. Bear. So I wanted to acknowledge this. And then without further ado, this is our speaker, Mike Bricker, and I'm going to let him tell you a little bit more about himself once he gets his slides up, and we'll get going here. So I'm going to stop sharing my screen, Mike.
Okay, thank you very much, Megan. And I just, as an aside, okay, got it. I've been presenting with the National Native American Alaska Native Mental Health Technology Transfer Center for a number of years, and I'm very sad to see this the transition. But you know that life is about transitions, and so good things will be coming. And so please stay tuned to the ATTC or MHTTC websites to see what's going to be coming next. My name is Mike Bricker. I'm a mental health clinician. I've been working in Indian country for a number of years. Worked in Alaska for 12 years. Worked on the Navajo Nation for a long time. But most recently, I've been interested and involved in doing medication-assisted treatment. Megan, are you able to see my slides?
Not yet.
Okay, so it's the screen share.
Go ahead and try sharing your. Yep, screen share. Go pick your slides, and then they should come up once you select share.
There we go. How's that?
There we go. That's starting to work. Hold on. And it says Mike. Yep, there we go.
Okay.
Now
cool.
we can all
okay,
see.
thank you.
Thank you.
So why? That's just a little bit about me and how to get a hold of me if you're interested in doing that. One of the reasons that this is so important to me is that besides being a person in long-term recovery, as a clinician, the only thing that I don't like about the work that I do is that I've gotten tired of burying people that I've come to like. I've lost 3 people already this year to substance use related deaths of various kinds. So even more importantly, the overdose rate for Indigenous people is way more than twice the average for the rest of the total population. And so we're faced with, as clinicians, as tribal members, as community members, as human beings, we're left with the question of what now? What are we going to do? How are we going to be able to respond to this? So a couple of things that I hope you'll be able to take away from today. we're going to look at 3 methods to reduce the impact of opioid overdose deaths, particularly in Indian country, to look at a couple of philosophical and practical considerations between what more traditional abstinence-based and medication-assisted treatment modalities. This concept is not nearly as controversial as it was 10 or 15 years ago when I first started doing this kind of work with medication-assisted treatment. Looking at what are the FDA and DEA approved medications, and there also are some experimental ones, particularly for methamphetamine use, and become familiar with evidence-based medication-assisted treatment resources, either designed for or adapted to Native populations. So that's kind of our work for today. It's no secret at all that the overdose, the opioid crisis has been growing over time. But when we look at overdose deaths by gender, we see this incredible rise, and particularly accelerating in here, which is when oxycodone became such a part of the treatment of chronic pain, which, by the way, was pretty much of a, as some of you may know, pretty much of a conspiracy by the pharmaceutical industry. They convinced the Joint Commission on Accreditation of Hospitals to register pain as the 5th vital sign, along with pulse, respiration, blood pressure, as a way of marketing, basically, OxyContin. Looking at Indian country, however, among Native American Alaska Natives, we've seen this 3-fold increase in a 10-year period of time, a horrendous burden. Real quickly, these are in your handouts. I'm not going to read this whole thing, but looking at opioids, there's a difference between opioids and opiates. We'll get to that in a second. Looking at these overdose death rates among Native populations, there is good evidence from the FBI and from the Drug Enforcement Administration that Mexican cartels are actually specifically targeting Indian country because of high unemployment means that many people are turning to trafficking and dealing as a way of making money. Also, among Alaska Native and Native Americans, the overdose deaths have more than doubled between 2010 and 2021, and particularly paying attention to the 15 to 24 age group. So heroin overdose deaths have been somewhat, to a certain extent, eclipsed by the fentanyl crisis. But it's important for us today to remember that this is not just about opioids. It's not just about opiates, because people who use opiates are using other substances as well. People who are addicted are twice as likely to have problems with alcohol, 3 times as likely, and I'm not going to read you the slide. These are more likely to be addicted to heroin. So we're also going to talk a little bit about medication-assisted treatment for tobacco, alcohol, and methamphetamine. Fentanyl. Most overdoses, particularly among young people, they don't know that their drug is laced with fentanyl because they're so good now at counterfeiting other what look like legitimate prescribed medications that you would get from a pharmacy. And also, some of them are just kind of rainbow-colored pills. They look almost like Skittles or M&Ms that are really targeted at our youth. So, cannabis is still one of the biggest uses among high school age kids. But when you look at this, high school students using inhalants, using methamphetamine, using heroin, these are 15, 16-year-old kids. Here's some stuff about how to protect your family and your community. Please, these are in your handouts. They're public domain. They're free to download. Please feel free to take them and use them in your community and in your family to help bring some awareness and some consciousness, some mindful impact to battling with this. Heroin, people think that heroin is such a huge problem. Actually, this slide shows that actually addiction to prescription opioid pain relievers much higher. And in fact, I'm going to back up just for a second. One of the reasons that people have gone back to heroin is that a couple of years ago, the FDA kind of shut off the faucet for prescribing opioid pain relievers for almost anything. And so when there was no longer available, now then people turn to heroin. So now more than 750,000 Americans lost their lives. This is roughly the population of Toledo, Ohio. You know, each individual death is tragic to the person and to the families and to the tribes involved, but it's a part of a much bigger picture. And then again, part of the problem is the treatment gap. There is so much demand and so little resource. So why do we need medication-assisted treatment? Well, it's been shown very clearly that as the medication-assisted treatment has risen over the past 10 years or so, that opioid overdose deaths have declined. I mean, it's pretty astounding. Now, just very quickly, the difference between opioids and opiates. Opioids are present, they all come from the poppy seed, from the poppy plant. So things like opium, morphine, codeine, and things like this, they all exist naturally. They have been used for thousands and thousands of years by native practitioners for all kinds of things. Western medical science then probably wasn't content to leave nature alone. And so then they developed these semi-synthetic opioids that are derived from an opiate. For instance, heroin is derived actually from morphine, and then purely synthetic opioids that are actually created in a laboratory. For instance, methadone and now buprenorphine. It's important to understand the difference between these three terms that you'll hear a lot as we talk about medication-assisted treatment. Opiate agonists. It comes from the Greek word agona, which is a wrestler. And antagonists block the effects of opioids. The one that most of us have heard about is Narcan or naloxone, that actually blocks the opiate receptors. Even when somebody is having an overdose, it actually displaces the opioid molecules at the mu receptors. And that's why Narcan will wake people up. There's also prazosin, which is used for alcohol, and acamprosate. Both of those are used. Those are both prescription medications that can be used for alcohol. Agonists are drugs that have an affinity for the target receptors in the brain. They actually make the thing fire. The ones that we are most familiar with for opioids are methadone, has been around for a long time. Benzodiazepines have been used for many, many, many years to help people with alcohol withdrawal. Then we have this new class of medications, which are called partial agonists. Buprenorphine, what it does is, yes, it attaches to the receptor sites in the brain, and it does so enough that it keeps away the symptoms of withdrawal, excuse me, but it doesn't allow the euphoric effect, the bump, the buzz that which is the reason that people use. Not only that, buprenorphine has a limiting effect. If you're drinking alcohol, the more alcohol you drink, the higher you get. If you're smoking cannabis, the more cannabis you smoke, the higher you get. If you're using heroin, the more heroin you use, the higher you get. With buprenorphine, there's actually a ceiling effect. So the more you use, the less you feel, not more. And so there really is no incentive for people to overuse buprenorphine because it doesn't give you the high that you're looking for. Then it can be used by itself or combined with naloxone, and that's Suboxone. And that's one of the main things that we look for in doing medication-assisted treatment. We talked about methadone. Traditionally in methadone, in Indian country, there were no, now this may have changed. I believe that there's now one licensed opioid treatment center by the DEA. But historically, that just wasn't available on native reservations. People who were lucky enough to be close enough to an urban center could probably go to a methadone clinic in town, but on the reservation or in some of the more remote areas, it just simply wasn't available. So these have to be federally licensed. They're very strict. it's pretty much limited to urban areas. So this severely limits the treatment options. Now we have buprenorphine. Buprenorphine is more accepted and more widely available in rural areas. So buprenorphine has been around for quite a while, 20 some years. It was first approved back in 2000, and Suboxone and stuff like that. But there's been very recently, there has been a big difference, and that is just this year. Up until now, the people had to have a special waiver. You had, besides a DEA license to prescribe any kind of controlled medication, physicians, nurse practitioners, and physician assistants had to have also this special data waiver training that they had to take. And it was like 2 days worth of training that they had to take in order to be able to prescribe buprenorphine or Suboxone. Plus, they were limited to the number of patients that they could take. In this year, that all went away. In January of this year, the FDA removed all of those restrictions. There is no longer that waiver, or there is some extra training that they request, but there's no limit on the number of patients that a person can, that a provider can prescribe for, which really opened up the opportunities for people to get treatment. Detox. Detox is not treatment. Medically supervised withdrawal or acute detoxification. Yes, we can put somebody into the hospital. We can detox them safely using clonidine and some benzodiazepine, sometimes Klonopin. I'm not a physician, by the way, so this is an uninformed medical opinion. But what happens when people then leave? If they're not engaged in some kind of treatment, the relapse rates are astronomical. I mean, at 1 year, less than 15% of the people who were detoxed are still abstinent from the drug of choice. Not only that, there are increased rates of overdose, because when you get detoxed, your tolerance for the drug goes down. So if you've been sober and kind of hanging on by your fingernails for 6 months or so, and then you decide to use again, your tolerance is here, but the lethal limit is here. And so most opioid overdoses before fentanyl anyway happened when people were in a state of relapse. This is how that's all measured. You don't have to know this necessarily unless you're a prescribing provider, but there's something called the COWS, the Clinical Opioid Withdrawal Scale, that helps to see what level of detoxification or withdrawal you're in. This is used by medical providers or prescribing providers to know when to initiate buprenorphine. They have to wait until you're in a little bit of withdrawal, not the full-blown, but there has to be a certain level of withdrawal before they will introduce the buprenorphine, and that then helps them to kind of titrate the dose. Why do people relapse, either after just detox or as they go forward? Something called the protracted abstinence syndrome. It's a kind of chronic withdrawal. Those of you who are familiar with drug and with alcohol treatment, Terry Gorski identified post-acute withdrawal, which is actually a state of unrest and unease in the nervous system, even though the drug is no longer there. The big ones with opioids are this kind of malaise, this fatigue, insomnia, bad stress coping mechanisms, really increased craving for opioids, and then also condition triggers. I mean, this is one of the reasons that we say, avoid people, places, and things where your drug is being used. And often what people will do is they'll try priming with a small dose of the drug. If they're injecting heroin, they'll do what's called skin popping. They'll just inject it just under the skin, then they get a little bit of a rush, but not as much as when they use it intravenously. But all that does is reactivate the craving cycle. The craving, we won't get into the details of this, but all drugs of abuse work here in the limbic system. If it doesn't light up the limbic system, you can't sell it on the street. But heroin in particular, there are millions and millions and millions of these opioid receptors in here because that's part of the pain management system. There's many, 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 many neurons in this area, and you'll notice there aren't all that many up in this area. This is the part that wants to use. This is the part that says, no, thank you. So if you think about this as this is the gas pedal, these are the brakes. So this part of the brain still continues to crave for quite a while. Those of you who are clinicians and counselors are familiar with these are the DSM-5 symptoms for opioid use. There's a very predictable pattern for almost any drug, but particularly we're talking about opioids now. What happens is, people begin to use because it makes them feel good. They get this feeling of euphoria. But over time, tolerance begins to develop, and so the same amount of the drug doesn't do it anymore. So now they're increasing their drug use to try, it's called chasing the dragon or chasing that first high. They're trying to use more and more of the drug in order to be able to get that same feeling, but they can't really get there anymore. And so finally, what begins to happen is they get to a point where they're no longer using to get high. They're just using to avoid withdrawal. That's really it. They can't use enough anymore to get high. And so what happens, as we all know, is if this goes unchecked, jails, institutions, and death, as Narcotics Anonymous tells us. We talked about tolerance. That says that we have to use more and more of the drug to get the same effect. Physiological dependence is the symptoms of withdrawal, particularly with rapid opioid cessation. But why medication-assisted treatment? What's that all about? Well, with medication-assisted treatment, we're able to interrupt this cycle by introducing these opioid agonist therapies like methadone and buprenorphine. What happens is we're able to bring people back into the window of tolerance. Yes, there still is a substance with addictive potential that's in their nervous system. Yes, that is true. But they're able to function. They're able to work. They're able to get their kids back from child welfare. They're able to hold a job. They're able to participate in ceremony. They're able to go to powwow. They're able to become part of the community again. So what are the medications? Really, the medications that treat opioid use disorders, the main things are they alleviate those symptoms of the physical withdrawal by blocking those opioid receptors. They diminish and alleviate the craving for the drug, and they help to normalize and stabilize that brain neurochemistry that's been so upset by the drug use. These are the options. Opioid antagonist, naltrexone, is a full opioid agonist. And so if you take naltrexone, you can take an opioid and it will do absolutely nothing. It won't give you a high. Unfortunately, you can still use enough to get the respiratory suppression and overdose, but you're not going to get the effect that you're looking for. And then we have the opioid agonists, methadone, which is a full agonist, and buprenorphine, which is the partial thing. Remember, and this is one of the key differences in looking at medication-assisted treatment as opposed to more abstinence-based forms of treatment. Our primary goal is we got to keep them alive long enough to establish the recovery process. That's the goal, is to keep them alive. So let's take a look at our biases. I mean, we all have them, and this is not you don't have to answer these questions, but ask yourself these questions. Do you think that a person in long-term opioid maintenance with methadone or buprenorphine, can they be considered to be in recovery? No, that's not a no-brainer question. And the answer that you have to that question is your answer to that question. There's no judgment here. But most people will find themselves in one of these three categories. Either they say, no, they're still taking an addictive substance, and I'm glad that they're doing better, but they can't be considered to be in recovery in the sense that most of us use that term. Yeah, as long as they're taking it as prescribed, it's okay. or only if they no longer exhibit the other symptoms of substance use disorders. In other words, as long as they don't have the behavioral aspects that are so much a common part of the disorder. Let's look at treatment with buprenorphine and look at what are some of the myths and what are some of the facts. It's a very logical question to say, look, isn't this just another drug? Well, let's look at it. First of all, this is a drug. The motivation to use a drug is the ward. You want the euphoria. You want the feeling. Well, buprenorphine and methadone, those are prescribed medications that are prescribed to treat an illness. The way I talk with my patients is, a medicine is something you take to get well. A drug is something that you take to get off. Get off in the sense of get high. The pattern of drug use is marked by these dosages of administration that create these huge spikes and slumps in the nervous system. The pattern of a medication is marked by fixed dosing schedules and methods of administration that really minimize that and have a steady state in the person's bloodstream. Drug use is characterized by self-monitoring, controlling and medication, and monitoring of medication is maintained by treatment with your providers. Boy, that's interesting. The net effect of medication use is a progressive improvement in the quality of life. The characteristics of an addiction is a progressive deterioration. The effect of medication use in recovery is a progressive improvement. Drug use, other than medication is taken within the laws that govern its manufacture, its sale, possession, and use. Drug use is often accompanied by other self-destructive, socially harmful behaviors. Medication is used by other health-promoting and recovery-enhancing behaviors. The social determinants of health begin to build back in, the spiritual awareness, the connection with the community, all of those things that are so important begin to arise again. So, myth number one, patients are still addicted. Well, addiction, remember, is a pathological use of a substance that may or may not include physical dependence. Those of you who are clinicians and do diagnosing, everything in the DSM-5 says must cause clinically significant impairment and distress in one or more life domains. That's the definition of addiction. Physical dependence on a medication does not mean the person is engaging in other pathological use and dysfunctional behaviors. Somebody who is in hospice care for terminal cancer and receiving, huge doses, they're not breaking into people's houses to get more of their drug. It's just not happening. Buprenorphine is simply a substitute for heroin. Well, it is a replacement. It's not a substitute. This is particularly true for buprenorphine. Buprenorphine is legally prescribed, not illegally obtained. It's a medication that's taken sublingually, which is a very safe route of administration, and it allows the person to return to some normalcy of functioning. Providing medication alone is sufficient treatment for opioid addiction. If you don't take anything else away from this workshop, please remember this. Prescribing these medications alone is not treatment for recovery. Providing medication is not enough. It's important, but the complete treatment package has to have all of these other elements as well. Combining the pharmacotherapy with counseling, ancillary services, case management, job coaching, all of these other things that are a part of the recovery process have to be present, or otherwise it's not really treatment. It's not really recovery, in my opinion. Patients are still getting high. Well, when they're taken sublingually, either the pill or the film, buprenorphine is very slower acting. It arises to a steady state in the bloodstream very slowly. It decreases in the bloodstream very slowly, so you don't get that rush, which is what you're using for it. Also, buprenorphine has this ceiling effect, meaning that the more you try to use, the less euphoria you feel. So buprenorphine has been shown by tons and tons and tons of studies to be at least as effective as methadone in primary outcomes of abstaining from illicit use, keeping people engaged in treatment, decreasing their cravings, and particularly accidental overdoses. This is the thing. You can't get them sober if they're dead. Bottom line. So oral naltrexone. Oral naltrexone, duration of action anywhere from 24 to 48 hours. Been around for 40 years now. Tons of research about it. The oral naltrexone is most beneficial for highly motivated patients. Either they're highly internally motivation, for instance, impaired physicians who are doing random urine drug screens. If there's any evidence of continued use, they lose their medical license. Very, very strong incentive to stay with the program. Close monitoring and frequent urine drug screening. However, there's much better research on outcomes for alcohol, which we'll get into a little bit later in the presentation today. It is not particularly effective for medication-assisted treatment for opioids. It can be done, can be used, particularly the injectable form, the Vivitrol, which is the month-long thing. But there are different formulations of buprenorphine. The combination, which we call either Subutex or Suboxone, which is the combination of buprenorphine and the medication naloxone, which blocks the opiate high, or just buprenorphine alone. Buprenorphine, by the way, can be used off-label for pain. I have a couple of pain patients that are getting very effective pain relief, and they're not on OxyContin anymore. There are also parenteral and transdermal patch forms. Butrans is one of them. They are approved for pain, but they're not approved for opioids, and you can't use them off-label for opioids, or at least that was true when the first time that I did this presentation, which is about 10 years ago. I should probably update that. Anyway, what is the purpose of having the combination naltrexone and first of all, naloxone doesn't really get into the bloodstream. So when you take the medication either orally or sublingually, the naloxone really doesn't do anything. But if you dissolve it and inject it, all of a sudden the naloxone is there like gangbusters, and it completely blocks the high. The combination product, either Subutex or Suboxone, if you crush it, dissolve it, or inject it, it causes initial withdrawal if the person is physically dependent on opioids, and the naloxone blocks the effect of the buprenorphine. So therefore, it's really safe for diversion purposes. The bioavailability, if you dissolve it sublingually, the naloxone does nothing. The buprenorphine does what it's supposed to do. The naloxone is just along for the ride. If you swallow it, same thing. Buprenorphine really isn't active because it doesn't really work very well in the stomach. And also the naloxone doesn't. But if you inject it, yeah, the buprenorphine is active, but the naloxone just really crushes the high. So the other advantage is that both of these, for dosing purposes, it's not timed released. So the tablets or the film can be split and divided and so forth. So buprenorphine, highly safe, very, very safe for both short-term and long-term use. Does it have any side effects? Well, it's an opioid, so there's some danger of constipation, but much less severe, and usually goes away after a few days. There's no evidence of significant disruption in cognitive or psychomotor performance. In other words, you're not likely to get arrested for driving under the influence if you have a steady state of buprenorphine in your system. And there's no evidence really of organ damage with long-term dosing. I mean, certainly not as damaging as alcohol, or, I mean, everything goes through your liver. But very, very safe. Is there abuse potential? Well, yeah. If you're not opioid dependent and you take buprenorphine, you're going to get a rush. Not a big one, not a terrific one. But the abuse potential is way less than methadone, for instance. Abuse among the people it's designed for is really relatively low. The combination route, theoretically can't be abused by injecting IV, but really, and I run a number of medication-assisted treatment programs. Really, most illicit use is people diverting the medication so they can give it to their friends or to treat withdrawal and cravings. There was a big thing, one of the programs that I managed a couple of years ago, guys were sewing it into the elastic band in their underwear when they went into prison or went to jail for a DUI, so that they wouldn't go into big time withdrawal while they were in there. So be careful. This is one thing. Be really, really careful of using sedative hypnotics along with buprenorphine. Using alcohol or benzodiazepines, most deaths have resulted from injecting buprenorphine and benzodiazepines at the same time, trying to get a high. Avoiding alcohol, or particularly excessive alcohol use, is important for avoiding overdose. So identifying these folks who are willing and able to also get into full recovery from their other substances that they use. Frequent urine drug testing is critical. I believe that doing medication-assisted treatment that does not include random urine drug screening is malpractice, my opinion. And often what happens, particularly with office-based providers who are just they're prescribing the medication and come see me in a couple of weeks and we'll give you a refill. Well, they do a urine drug screen when they come into the office for their appointment. And any addict worth the name knows how to beat that system. It has to be random and it has to be fairly frequent. So looking something that's new on the horizon, and this is really only the last couple of years, we have now these extended release buprenorphine formulations where you can get them for a month rather than having to take the daily dose and get the, and you get an envelope with a bunch of these little films in it or a bottle of pills. Once you're established, you can be transitioned to this extended release after a week or so to make sure that you're stable and things are going well. There are a number of reasons why this is perhaps a good idea, particularly in rural communities. The convenience of not having to carry and self-administer this medication every single day. If you are on a reservation and you are herding cattle or sheep, you may be out, you may be out on the range for days, sometimes weeks at a time, carrying a whole bottle of pills around and the chance of losing them, which taking the medication daily helps it to be on a consistent basis. Patients understand that resuming use may be easier if they just have to stop taking their medication for a couple of days, let it wear off for a couple of days, and then maybe I can shoot a little heroin or take a little OxyContin, and then I'll get back on, buprenorphine. Doesn't work that way. The patient preference, especially if they have some nausea, but this one is really important in urban areas. People who are unhoused, people who are experiencing homelessness, people who don't have a safe place to store medications. It can be really, really helpful. It can be really a lifesaver to have that monthly injection that you get, and then you don't have to worry about it. So there's a new one that just came out. It's called Brixadi. The long-acting buprenorphine is a 1-month shot. It's every 30 days. Sublocade is the monthly dosing indicated for moderate to severe opioid use disorders, prescribed as part of a treatment plan that includes counseling and psychosocial support. The dosage will be titrated by the prescribing provider to make sure that it's effective. Brixadi can also be done weekly. And so you can have the month long, you can have the week long. It really increases the flexibility, particularly if you're looking at tapering off of the medication assisted treatment eventually. Those of us who grew up with abstinence-based treatment models, you know, we kind of think, well, we really ought to get them off of everything. Opioids, particularly long-term heavy opioid use, changes brain chemistry forever. And so the statistics for people kind of weaning off of Suboxone and going to nothing, relapse rates are very, very high. If we say that addiction is a disease, if you're diabetic and you get your A1C down below 7, we don't take you off of your metformin. If you have high blood pressure and you get yourself down to 120/80, we don't take you off your blood pressure medicine. Different way of looking at it. Injectable naltrexone, we talked about. Vivitrol, it's a 30-day supply. Particularly effective for alcohol, which we'll get to in a minute. So asking yourself as a counselor or as a community member, how comfortable would you be in having, you know, in working with folks who are on medication assisted treatment? There's no wrong answer here. Whatever your opinion is your opinion. But maybe at the end of this, you've had a chance to think about some things a little bit differently. If you want more information, this is where to get it. Looking at the assessment process, again, before you begin, what are your biases? If you're a counselor who is doing assessments, what are your biases? Most of our people have spent most of their lives around people who don't like them. And so their radar out to here, they're always scanning the environment for people who don't like them or people they can take advantage of. Be real clear what your opinions are. Biopsychosocial assessment, we're not going to belabor this. You all know what's involved. Physical exam and labs, full mental health assessment, including the Adverse Childhood Experiences Survey. And I actually have an adaptation of the Adverse Childhood Experiences Survey that focuses on resilience. And there's a version particularly designed for Indigenous populations. So coming up with a diagnosis, frequency of urine drug testing, absolutely essential. What is the treatment setting? The more support, the better. Simply office-based treatment can be effective. Office-based treatment plus outpatient counseling can be even more effective. Outpatient counseling and intensive outpatient is even so. It's like the continuum of care. Looking for acuity, length of use, and particularly the community supports. Often the people that come to see us have blown through all of their social supports. Their family, their tribe wants to have nothing to do with them. They're pretty lonesome, so we have to really pay attention to that. Particularly warn folks about the risk of overdose if they stop using and then resume opioid use. That's when most overdose deaths happen during relapse. The two main forms of buprenorphine and naloxone, the pills are called Subutex and the films are called Suboxone. They're available in various dosages and things. Now, looking at adolescents, treatment, looking over here, 15 to 24, kids are dying. Treatment options for opioid addicted adolescents, and often this is along with cannabis. This is one of the first drugs that they use because they often are stealing pain medication from somebody. Buprenorphine is FDA approved for use with persons age 16 and older. Lots of good research supporting that medical treatment needs to be longer than, with almost anything else. We know that adolescent treatment for alcohol takes longer. Use in a pharmacologic treatment. Buprenorphine is the first line treatment. First of all, most methadone clinics, besides there not being a lot of methadone clinics for Native populations, can't admit patients under 18 years old. So methadone may be a good option, but naltrexone is also an option. So if you want to get more information, again, this is the ASAM, the National Treatment Guideline for Opioid Use Disorders. Again, not just opioids. Cigarette smoking is more common among Native American, Alaska Native folks than any other racial and ethnic group in the United States. Smoking increases the chances of losing members of your tribal community to smoking-related illnesses, increases the chances of losing elders to smoke-related diseases or exposure. It's a problem. Tobacco is sacred, smoking is not. Psychostimulants, methamphetamine is most commonly abused drug on most Indian populations. Alcohol, we all know about alcohol, and so methamphetamine, most people with opioids abuse other drugs as well. Methamphetamine, we don't really have good dedicated medications. Here's some information on a recovery guide, but we have a couple of things that are considered off-label. Paxil is one of them. Provigil and mirtazapine, which is a antidepressant, and also naltrexone can be used for methamphetamine abuse. I used naltrexone pretty effectively in the methamphetamine drug court program that I ran for a number of years. But there's a considered off-label uses, and they work better for some folks than for others. Tobacco use, 2 quit smoking medicines approved by the USDA, bupropion, which is also Zyban, or Wellbutrin in its antidepressant form, and Chantix. Also, nicotine replacement therapy can be, the patch or the gum can be a very good intermediate step. Now, abstinence from alcohol. Pharmacotherapy for alcohol dependence. Antabuse has been around since the middle 1950s. In 1994, Revia naltrexone was approved, and now Compral is another medication that we'll talk about just real quickly. Compral is very effective, acamprosate, very effective, but it's 3 times a day dosing, and so compliance can be a little bit of an issue. But look at the difference in outcomes. A year later, the recovery rate is almost double for placebo, and particularly these crucial areas in the first half year, really effective. Antabuse, disulfiram, makes you violently sick if you use alcohol or use anything else that has alcohol in it, like alcohol hand washing, perfumes. I stay away from it. I had one patient who was on antabuse for a very long time, many years ago. I don't tend to use it. Naltrexone, much better compliance in outpatient settings for alcohol than for opioids. How does it work? We talked about this. It blocks the receptor sites that generate the high, that generate the buzz. So naltrexone with alcohol, it blocks the buzz, but not the hangover. I mean, you can drink enough to overcome the blockade. You can drink, if you're taking naltrexone, you can drink enough to get a little bit of a buzz, but you're drinking way more than the amount that's going to give you a pretty good hangover. So scientific research, again, terrific compared to just therapy alone, counseling alone, cognitive behavioral therapy, coping skills, 3 times better with supportive therapy and naltrexone. This is the extended release, the monthly shot, vastly preferable to oral formulations for preventing relapse because it's in your system, it's there all the time. So looking at counseling, this is counseling 101. You've got to be flexible. Don't use a lot of high expectations. Confrontation isn't usually very effective. It can be, but only if it's used very gently. Particularly being non-judgmental and using this motivational interviewing approach. So what are the benefits of recovery? People, you can't scare people into recovery. It just doesn't work. I can't do anything to them that's worse than what their disease is going to do. So scaring people into recovery just isn't very effective. Stressing the necessity of staying with counseling for a long enough time. We have to recognize that patients may have some ambivalence regarding medication. It just never ceases to amaze me when I talk about medication. They say, "Oh no, I'm not going to take that prescribed medication. I'd rather go slam some dope that I don't know where it came from or how strong it is." Yeah, really. One thing to be aware of is that there still is some stigma in the recovering community about patients who are taking medications. So counselors have to be aware of what their biases are and the biases in the community that they operate. Medication alone is not sufficient for treating any kind of drug addiction. Patient monitoring goals for treatment have to include things like no illicit opioid use or other drug use or diversion, absence of adverse medical effects, behavioral patterns beginning to change, responsible handling of their medication and adherence to whatever their treatment plan is. Now, issues with 12-step meetings. I'm happy to report that the Wellbriety movement, the Red Road to Sobriety, has been much more progressive in dealing with folks who are on any form of medication-assisted treatment. Traditionally, Alcoholics and Narcotics Anonymous have been more reluctant, even though there is a program from Alcoholics Anonymous World Services that says we are not doctors. It's called the AA Member Medications and Other Drugs. We are not doctors. NA says in the White Book, the ultimate responsibility for medical decisions rests with each individual and their provider. So some meetings are more accepting of medications than others. Counseling approaches, motivational interviewing approach works very well. There is a blending initiative that includes motivational interviewing and some other things. It's available from the ATTC network. Motivational incentives, providing incentives for clean urine screens. Terrifically effective. How long should we be doing this? Well, there's really no long-term data. How long is safe? But studies as long as 16 weeks show high relapse rates. Patients can be retained long-term, 75% retention at 1 year with maintenance. I mean, how many of your treatment programs can say that they have 75% completion ratios? Continuing maintenance as long as the medication is being beneficial. Relapse prevention, simple stuff, dangerous emotions, be smart, not strong, avoiding relapse drift. Triggers. Triggers are, we talk about those a lot. Excuse me for a moment. Triggers a stimulus been associated with the preparation, anticipation, use of drugs or alcohol, these in people, places, and things, times of day, and so forth. But I got a question for you. In a firearm, in a gun, what exactly does the trigger do? But when I ask that question, usually people say, well, it shoots the gun or it fires the. No, the only thing that it does is it releases the firing pin. That's all. So if I don't have a relapse bullet in my gun, when I get triggered, it goes click. Not a big deal. So cravings are not as big, or triggers are not as big a thing as we sometimes make them. However, craving can be. So we really need to pay attention to craving management skills. Triggers and cravings. This is from the matrix model, the trigger, thought, craving, use progression, but it's not always linear. We're working with native folks. We know that everything's a circle. There's no straight lines in nature. So the relapse process isn't always linear. It can start in any one of those 4 elements. So the key is to look at each one of those. What's the thought? What's the craving? And having another plan. And this, by the way, is in your handouts. You're welcome to use it. Cognitive behavioral therapy is also can be really helpful. There's a very predictable progression of cognitive distortions kind of reintroducing themselves. And again, what are you going to do instead? What's your pattern for each one of these, and what are you going to do instead? Plan ahead. Now, this is the real cool stuff. Medication-assisted treatment for Native populations. SAMHSA has tribal opioid response grants. However, there are a number of other things that are available outside of that formulation. Tribal opioid response grants, if your tribe is lucky enough to have one, it's great stuff. But even if your tribe doesn't have a formal grant, a lot of the stuff is available. You can still get it. You just don't have the grant to support the work that you do. Particularly looking at the cultural practices that are so much a part of the healing process for our people. Native Connections, looking at opioid and overdose prevention in Native communities. That's where the website is. If you want to get this fact sheet, you can get it from there. I think I also included it in your handouts, but I forgot to put it on the slide. Sorry about that. So even if your tribe doesn't have that the TOR grant, these resources are still available through the National Indian Health Board. If you want a more comprehensive look, this is a little bit more scholarly, but tip 61 from SAMHSA talks about behavioral health services, including anxiety and depression and PTSD and all kinds of other things, but it does include a lot about medication-assisted treatment. Those, again, the TOR grants. Our friends at the National American Indian and Alaska Native Transfer Centers, which are hosting us today, provide education and training opportunities. I'm sorry to hear that that the grant will be sunsetting at the end of September. Hopefully, there will be a way to continue to make the excellent resources. I mean, if you go to their website, there are hundreds and hundreds of trainings that have been done over the last 5 years, the life of this grant. There's more stuff there than you could use in 5 lifetimes. So please, hopefully there'll be a way, Megan, to for Elaine and you guys to keep that website active. Walking in the Beauty Way, looking at the and this, I think, is really important. We think of addiction as a brain disease, and it's a great way to reduce stigma, but putting the brain at the center of everything, kind of a colonialist, Eurocentric way of looking at things. We need a more holistic view that goes beyond just a person's biology. We have to integrate culture, societal factors, spiritualities into the mainstream medical institution and the work that we do. It has to be there for our people. Centering culture in the treatment of opioid use disorders. These are 2 kind of mind map things that occurred in a journal of psychology. The whole point here is it's holistic. The center of it is not abstinence. The center of it is healing. So this is a good webinar that's available. The citation for it is down below if you want to get that. 7 directions coming from Minnesota, University of Wisconsin, University of Washington. I'm sorry, Department of Psychology. Wonderful information. This is some information from them. Again, there's a YouTube there that is well worth the time to watch it. California has some wonderful responses to the opioid crisis in Indian country. Again, there's the resource. This is something that you should download and print if you're going to be doing medication assisted treatment. Talks about naloxone. Naloxone is now available. It's been distributed by the federal government. It's also now available in pharmacies without a prescription. Kind of spendy. Where I am in Western Oregon, it's about $40 for 2 doses. But you know, that's a little bit more than a 20 sack of meth. Naloxone saves lives. Again, this is the flip side of that poster. So as we bring this to a close, how do I know when I'm ready to stop? Well, look at the whole person. Recovery is not about abstinence. Abstinence is an initial step. It is the first step on the road to recovery, but by itself, it's not enough. So looking at these different life domains, medically, is my overall health, including my mental health, is my overall health being managed in a healthy way? Do I have a stable and safe place to live? Now, it may not be the traditional home that we think of, but you know, do I have a stable place in a shelter? Do I have a place in a safe village? What is my life about? What is my purpose? One of the things that I'll often do with folks in recovery, and it sounds a little morbid at first, but I encourage my patients to write your epitaph. Not the eulogy. He was a great guy. He loved to hunt and fish. He was a great. No, one sentence tops that goes on your gravestone. When all is said and done, how will you be remembered? How do you want to be remembered? And when you begin to have that kind of a long-range vision for your life, day-to-day decisions about using or not using can sometimes be easier to make. And again, recovery is a contact sport. We have to have relations and a social network. Fortunately, for a lot of Native folks, that comes more easily than it does for my kind of disjointed Western social system. But recovery is a contact sport. We cannot do it by ourselves. We need the gifts of the Creator. We need the gifts of each other. We need the connections that we have in order to make it work. So I really want to thank you, not just for your attention today, but I really want to thank you for bringing hope, help, and healing to the people that you serve. The work that you do is so important. It's not just important to the individual lives that you save, that are saved because of the work that you do. It's the lives of the families. It's the lives of the children. It's the lives of generations yet unborn that are going to be safer and richer and more sacred because of the work that you do on a day-to-day basis. So when the going gets tough, we got to remember that. That's why we do this work. So this is how to get a hold of me if you're interested in doing that. I'm happy to bring things if you have a treatment program or a tribal organization, you're doing a conference. I'm happy to make myself available. If you would like a copy of the slides, what I would invite you to do is to scan this code with your smartphone. And by the way, it'll also work when you get a copy of the when you get the handouts, there's one in there. You don't have to try and do it now. But if you scan that code, it takes you to a website. You type in the words Native MAT, Native Medication Assisted Treatment, and it asks you a little 5-question survey. Was it nice? Was it good? Do you think you'll be able to use it? Is Mike a terrible presenter? And you ask, and then you'll be able to download a PDF of all of the slides. All of the work that I do is in the public domain. All of the work that I do is giveaway. And so please feel free to take that down, take the handouts, use them if they're useful to you. And I really do want to thank you for for your time today and for the work that you do. That, I guess, Megan, is it. Well, it's good. It's good to see
So
some, good
first
to
I want
see
to say
some.
thank you.
I just clicked on the gallery scene. It was good to see some faces that I've seen before. You know, Mary Lisa and Jean Weaver and some other folks that I've seen in other presentations. Karen, I'm sorry. Go ahead. The floor is yours.
Oh, no. Thanks, Mike. I just wanted to say thank you for providing us with all this wonderful information, and you have a lot of resources in here. So this slide set is very valuable. And so like Mike said, if he wants to get your feedback, you can do it via that way, or we will send you the slides. So either way, you should be able to have access to these and the recording. So the recording does take a couple days to extract, but it'll be on our website soon. I wanted to share with you, I'm currently in Palm Springs at a tribal healing to wellness court enhancement training. And one of our other consultants the other day, from the Montana drug courts, he shared with everyone a toolkit, and some people were asking about medication assisted treatment. And what we've done at our center, along with some other folks who collaborated, is we have taken a recovery toolkit and we've adapted it so it looks more cultural. So if you work with Native clients, this might appeal to them versus the previous Anglo version, which was just hideous. So I can honestly say that this one is
you're
very
right.
pretty. It has,
Hideous.
yeah. So I think I'm going to send that along to you guys
Please,
as
I'd love
well,
to see
because I think it could be useful in your work, and it guides you through everything, and it goes over like family, financial support, like housing. How do you get, if you live on a reservation, what, has all these options. So I think it'll be beneficial. It's available online, but I will send it to you directly with all the slides and our follow-up email, because it's important, I think, to share with people. So if you guys have any questions for Mike, you have his contact information. I must say I'm a little bit emotional right now because this is my last
Me too.
webinar in the center. And like Mike said, things change in life and we have to move on. I'm not ready for that because I am passionate about my work in the Native community, and I just want to continue. So hopefully something good will come along. But thank you all for joining. Mike, you did an awesome job as usual. You and I will be in touch, and anybody has any questions, feel free to get a hold of me. I'll put my email here in the chat. And like I said, you will get the slides in a couple of days. So thank you very much for participating. And I wish everyone well, and happiness for the future, and health. That's all I can ask for. So thank you, Mike. And I guess this will conclude our webinar. So thanks, everyone.